Well, good morning, and continuing with the amazing glaucoma session, and thank you all for coming in the early morning on day one to AIOS, and thank you very much AIOS for this opportunity. And I welcome my co-instructors, Professor Pandav, Dr. Faisal, Dr. Gaurav. I think Dr. Sunita would be joining us soon, and Dr. Rajul should be joining us as well. So I'll just give a quick intro as to what we are going to talk about. And this is going to be OCT in glaucoma. All of us who ultimately land up seeing glaucoma patients would be familiar with people coming with printouts of colors and being referred to you because it's red. And I thought it's a good idea to do an IC on looking beyond the colors and why the OCT is all about your clinical judgment and your clinical sense rather than what the color of that printout says. So can I have the first slide? Right, so I thought we could understand the OCT and look beyond the colors. Our fundamental take-home message in the next hour or so would be clinical examination is key. Red is not glaucoma, red may not be disease, and green is not normal. So at the end, I hope we'll all understand what to order, when to order, and why to order. So this is the course outline, and I welcome Dr. Gaurav, who will talk on basic concepts. Dr. Rajul isn't here, but we'll take Dr. Faisal next on what is normal and what is abnormal. Professor Pandav will talk about the current role of OCT angiography and what is its role. And Dr. Sunita would be joining us soon. She's in a session, was whether you can use the OCT to distinguish a glaucomatous versus a non-glaucomatous optic neuropathy. And then we'll follow this up with pits and pitfalls in the actual world. So Dr. Gaurav, if you could take over. Thanks.
Please not coming.
So meanwhile, I think all of us have the OCT. Let's just take a head call of how many of us use the OCT routinely for glaucoma practice. Routinely, so that's almost the whole hall. And how many of us use a combined OCT with the retina practice or have a dedicated OCT for glaucoma? I mean, do we use an OCT only because it's there or would we require it? So most of us do combine it with the retina practice, and that's why I think it's also become important. So there's some problem with the... can Dr. Faisal's talk come on by the time? Kidhar se? Preview room se? Oh, I'm sorry. So anyway, let's take questions then, now that we have time. Anything that has come to your mind regarding the OCT, I invite anybody asking anything, anytime, any questions. Yeah. Okay, so good questions. Do we have the glaucoma? We do. The Cirrus OCT does have a progression algorithm. They call it the GPA. The caveat is that as for all progression algorithms, the semantics have to be the same. So even a signal strength which is less than your baseline would come up as progression. That's one. And the other thing, most important to understand, is it is against a normative database. So the progression, unlike in a visual field, is not compared to a stable glaucoma patient. So that's something to keep in mind. And the second thing is assumes zero slope and does not take into account the attrition of the nerve fiber layer with age. So there is an age-related attrition, which is not there. It assumes that everything would be zero and does a regression analysis with a way that's zero. So it's important for us to understand what that progression is comparing against. So it's not comparing against. So in that sense, I don't think it's very robust. Yeah, Dr. Gaurav, finally, come. So Dr. Gaurav was with us. He's done a senior residency as well as a fellowship and is now a very successful practitioner in his own right, and we're very proud that he continues with glaucoma even when he's gone.
A very good morning to all. At the outset, I would like to thank AIOC and Dr. Sushmita and Dr. Pandav for giving me this opportunity to speak in front of you. So as ma'am has pointed out that red is not always abnormal and green is not always normal. So going back to the basics, I'll be telling what is normal, what is abnormal, what is red, what is green, so that we can interpret it in a better way. So OCT, the technology came in 1990 by Nahiro and James gave it this, and it is based on optical interferometry. The principle is basically different biological tissues have different light reflecting properties. So this machine uses that the echo time delay of backscattered light to give images. So basically, there are three main parameters relevant to detection of glaucomatous loss on OCT. That is retinal nerve fiber layer, the optic nerve head, and the ganglion cell complex. So all these three we can get on OCTs. So initially, the time domain OCT came, which just look at the echo time delay and give images. Then the spectral domain OCT came, which added a spectrometer, which uses that spectrometer to give more enhanced images. And the latest is now the swept source OCT, which has a higher wavelength, that is 1050, to give more enhanced depth in the images. So this is a routine OCT printout, no financial interest. So first we need to see what all is there in a routine OCT printout and what all we need to check. So there is our basic parameters and a signal strength. Then we need to look at the key parameters of the disk. This is the RNFL thickness map. This is the deviation map. This is a neuroretinal rim thickness curve. This is a RNFL testnet graph. Then the RNFL quadrant, RNFL clockers. So these all things we get on a routine OCT printout. So we'll look each separately. So initially the patient ID is very important. Many times our technicians do the OCT and they put wrong age or something like that, because OCT gives data on the base of normative database. If we will put age, sex differently, then the readings will not be accurate. And also it will only compare for normative database more than 18 years of age. So if we do a OCT scan of a child, then the readings will not be same. The most important here is the signal strength. We need to always look at the signal strength, because if the signal strength is low, the images will not be good and it will point out red. So the range is usually 0 to 10. So anything above 6 is acceptable. Like in this scan, we can see 8 is the signal strength. So OCT automatically outlines the optic nerve head, optic cup, disc borders, and also calculate more objective measurements such as optic disc area, neuroretinal rim area, in addition to the average vertical cup to disc ratio. So a 3.4 mm circle, RNFL circle, is always entered in the same spot within the cube, and it calculates RNFL thickness according to that circle. So these are the key parameters what all we get. So optic nerve head, optic cup, and disc borders is outlined. Then we get optic disc area, neuroretinal rim area. So everything is compared with the normative database, and it is pointed in red, yellow, and green. So in glaucoma, there is accelerated death of retinal ganglion cells and RNFL axon, resulting in characteristic visual field defects and corresponding optic nerve head changes. So OCT can directly measure and quantify RNFL thickness by calculating the area between ILM and RNFL border. So here we can see that 3.4 mm scan centered on the Brooks membrane is there, and the cube is 6 into 6 mm. So this is the thickness map. Here we need to see that the color coded thickness map is there. The blue is, the complete blue is 0 and the complete red is higher. So this is a normal hourglass pattern, that there is more thickness in the superior and the inferior quadrant. The main thing I wanted to point out here is that it has to be completely colored from blue, red, or yellow. It doesn't need to be black in any area. If the area is black in somewhere between, then it means the image has not been picked up. Then it will falsely give a thinning in that areas. Also, small optic disc, long axial length, and older rays are associated with thin RNFL. So this is an RNFL deviation map. So this is basically gives the absolute data, and it is deviation map, that is deviation from the normative database. So the gray here means it is normal, that it is not deviated. But in some areas, we can see yellow or red in the localized map. So it compares each point with the normative database. So small localized defects can be easily picked up many a time, because RNFL thickness comes at this 3.4 mm circle. But some areas like over here and over here, then localized defects can be easily picked up seeing at this grayscale map. This is a neuroretinal rim thickness curve. It has to be a double ham pattern. And this is a Tisnet curve. In Tisnet curve, here we can see the green, yellow, and the red. So this curve is compared with the normal normative database. So now, what is red? Does red means it is abnormal? No. Red just means that the data which we are getting is thinner than the 99% of the normative database. It may or may not be normal. Yellow means it is 1 to 5% of the normative database. And white, many times we see it comes white. So we see it is normal, but white doesn't mean it is normal. It means it is higher than the normative database, because in cases of like edema also, we can get higher thickness also. And in small disc also, the thickness increase in those areas. So here, this is a RFN quadrant map. And this is a clock hour map. So it gives thickness in each clock hour. So now I'll be coming to the ganglion cell analysis. The ganglion cell layer is thickest in the perimacular region, and decreased total macular thickness has been absorbed in glaucomatous eyes. So ganglion cell analysis consists of combined ganglion cell layer thickness and the inner plexiform layer thickness. So similar color coding is there in this also. Here we can see that right eye, there is complete red and yellow pattern, and here you can see the upper part is getting blue. It means there is a decreased thickness, and the color map also it is red. So this thing is very important in subtle changes. So with this, I would like to thank everyone.
Thank you. Thanks, Gaurav. I think in the interest of time, we'll have questions at the end. And meanwhile, I'd invite Dr. Faisal. Faisal represents Kerala in Chandigarh, and he is with us for a long time, done his PG as well. He's associate professor at the Advanced Eye Center, and he's here to talk to you.
Thank you, ma'am. At the outset, I thank Professor Kaushik and the AIOC for giving an opportunity for presenting this very informative topics today in the early morning. So Gaurav already told about how to read a normal printout and what is normal. Normal means your patient data fell within the 95% of the normative data. So why we are stressing glaucoma, as we know, is a leading cause of irreversible blindness throughout the world, and the structural damage precedes the functional changes always. So to get a field changes at a corresponding area, we need at least 25 to 30% ganglion cell happen before depositing on the visual field. So early examination is crucial. Structural imaging has a potential role for early pickup of the disease, so you can delay the disease progression. So imagings are objective and allow quantitative measurement also, help break perimetric glaucoma also. So what is a normal printout? Gaurav already mentioned. I'm not going to do a good signal strength. All the data should be labeled very nicely, and all the maps should be like you already explained about the segmentation, and also I'll be going through some cases. So this is a 62-year-old female came with angle closure glaucoma. Now you can on disc evaluation, you could see there is inferior thinning and disc hemorrhage and corresponding large area of the RNFL loss, RNFL thinning. And the OCT picked the lesion. The OCT RNFL shows this inferior thinning, and in the right eye, and the GCC picked this lesion like respecting the horizontal meridian. Why this GCC also picked the defect is wedge is so large which crosses the macular area as we traces peripherally. So this is another case. The green may not be normal. Why I said that the inferior there is a RNFL loss, thinning and RNFL loss, but see the superior part, you could see there is a small wedge-shaped defect, RNFL thinning, which is more marked on the red-free filters, but the OCT, the superior part shows as green in the quadratic map, also in the clockwise map, but the circle already picked this red area, but it's not displayed in the quadrant-wise or in the clockwise map, because it's taken average. The average fell within that normal limit. That's why it shows green, but the patient has glaucoma. The superior also there is a loss. So the quadrant alone, sometimes the lesion can be, the RNFL thinning may be so peripherally that may not come into the within the circle. Here you could see there is a RNFL thinning at the periphery, which was picked by the thickness map very well as a blue, marked as an arrow, and the OCT RNFL shows normal, but there is a field loss of nasal stop was corresponding to the RNFL loss on this picture. So this is another patient where there is a steroid responder. The inferiorly there is a wedge-shaped RNFL defect. The OCT RNFL picked the glaucomatous the changes, but the GCC became normal. Why it's happened? The thinning is extremely inferiorly, not crossing the macular area if you be traces peripherally. So this can be happened. There is RNFL peripapillary RNFL loss, but GCC may be normal in glaucoma. This we always keep to see the clinical exam, how to use it to correlate your clinical finding. Here the disc appears apparently normal in both eyes, and the OCT shows, right eye shows global thinning of the RNFL, peripapillary RNFL, and the GCC also global thinning. So on see careful examination of the macula, both eyes show this kind of lesion is maculopathy, and there is a on the OCT macula shows the changes in the macula. So the red in the GCC was not due to glaucoma, this was the maculopathy. So this another case, there is peripapillary RNFL was normal in the OCT, whereas in the GCC there is a red area, but this is almost whole quadrant loss. So should think about the other causes also, as this looks normal and good concentric neuroretinal rim. On seeing the fundus as a whole, you could see there is a changes of BRVO. So this BRVO changes lead to a thinning of the GCC. So myopia is always a problem for assessing the OCT. There is a disc lesser tilted and a large area of peripapillary atrophy. What happened to OCT? OCT shows even that there is a white. White we always means above the normal. We can see there is a large peripapillary area. You could see the scleral show also. Even that the OCT shows white. So interpretation of OCT is careful in high myopia here, and also segmentation will be a problem in high myopias. Like here, see the global thinning of the GCC, and the segmentation is not properly done due to high myopia. So this is another patient, 45-year-old male came with decreased vision both eye. The OCT shows there is inferior thinning and also some papillomacular bundle loss in the left eye. Whereas in the GCC shows there is a vertical lesion, vertical loss of the GCC, and the field forms a hemianopic pattern that is due to left homonymous myopia. So the glaucomatous GCC have a pattern of respecting the horizontal form, like first form as a horizontal raphe, then the horizontal area become widen and widen, and like that, not always the vertical lesions. So yes, OCT you can do a progression analysis also. You need a reliable baseline, then compare with the today's, that is an event analysis. You can measure the average. You can take a graph and the average RNFL thickness, and also the quadrant 2 eyes RNFL thickness also. If you don't have this software, you can see the each printout. Here the first printout, the first visual field was first OCT was, even GCC was normal. On following after 1 year, the GCC there is more thinning, the lesion become more pronounced. The lesion become more pronounced in the inferior part, and also similarly this picture, the quadrant initially was the yellow and later on it will become red during the course of the development. So the artifact can be seen in blinking, high myopia due to poor segmentation error. Always keep in advanced glaucoma there is an effect of floor effect. That means after a particular level the OCT won't be changed because they already reached the threshold lower level. That is due to underlying glial tissue and the supportive measures. So in advanced cases OCT may not be useful. So to conclude, the OCT is a widely used structural tool, and systematic interpretation is very important, and GCA is gaining popularity nowadays. And red lesion can be artifact, glaucomatous changes, or maybe non-glaucomatous, and not a substitute for your clinical skill and examination, but a good complement for your clinical evaluation, and kindly correlate clinically. That's all.
Thanks a lot, Faisal, for bringing in the clinical evaluation. Next, I'd be happy to call upon Professor Pandav, my mentor. He was head of glaucoma and now he's the head of department at PGI as well. And he's actually spearheaded the investigation of OCT angiography for glaucoma since it's come. So, Professor Pandav, sir.
Thank you, Dr. SUSHMITA, and good morning, everyone. It's nice to see a lot of bright faces this morning. You have heard about the OCT, and I think now we are getting a new tool there's the OCT angiography. The blood flow in glaucoma has always been an area of interest, and we actually don't have a very good way to study blood flow. So we have another tool, and I think this is being increasingly used now. So this provides us a non-invasive high-resolution imaging of the vasculature of the retina, choroid, and the optic disc region. And I will not go into the details of physics, but I think you know this basically. What you're doing is that you're taking an image, of a particular area of the retina, and that can be focused on a particular retinal plane, the end-face image, and it can go, before or after. Before, like you can change the level, so that will give you, the images, and you compare the one image from the next to the next, and each frame there's a difference in the reflectance, and then based on that you deduct, the software detects that, okay, this is a motion of the RBCs or something, and that's how. So it's a kind of indirectly you are computing the blood flow. So it's not giving you a direct measure of the blood flow, but this is an indirect computation of the blood flow. And this is how typically it would look like. You could image the retinal surface or go a little deeper in the peripelvic plexus, right up to the choroid. And you can actually match this with the regular OCT image. So this gives you a very good three-dimensional perspective and where the blood flow is, and what is happening to that. So if you look at the glaucoma diagnosis and monitoring, most of the time we have been depending on the functional testing of the visual fields, which still remains the gold standard for the progression as well as for the diagnosis. But in recent years, we have actually OCT, which has come up as a complementary tool. So it's almost as good as kind of both have to work together. Both have their advantages and disadvantages. We have just seen, some of the examples just before this talk. But now we also have an OCTA. So how we can use OCTA, that's what we are going to talk about in this talk. So the OCTA is, as I said, is a non-invasive, but what it does is that you take multiple images in different, different time settings and compare them with what's happening. So that will give you a progression, and also in a one-time image, it will tell you, where the capillary density is normal or decreased, and that will also give you, some idea of this is glaucoma or not. So the capillary density can be calculated, by that. So you have it framed there, and there are certain white dots in that which represent the, kind of the circulation, and you have some black areas which is the background. You just basically look at the ratio in a particular picture, and that gives you the vascular density. And then you have the software tool to calculate that, and also some kind of a flow index can be done. So areas of vascular density decline, and it's kind of it matches with the area of thickness on the nerve fiber layer and the OCT, so they match. So that's what gives confidence that maybe this tool can be used in glaucoma also. So what is the role of OCTA in glaucoma? So if you look at the vessel density and the optic disc index flow, then it has been seen that about 25% reduction is seen in glaucoma, early to moderate glaucoma, as compared to the normal healthy eyes. So that indicates that the glaucoma patients, they do have some reduction in the blood flow as measured in OCT. And also the areas of the vessel density decline in OCTA, they coincide geographically with the areas of the structural and functional loss. So that means on OCT, if you do, and if you find some thinning in a particular area, like in this picture that we are seeing. So if you look at the superior left corner of the image is a little darker than the rest of it, and which is marked by red arrows, and that basically suggests that there are lots of capillaries in that area, or the flow signal is less in that area. And if you do the OCT in that image, if you have nerve fiber layer thickness, then you can find this corresponding area also is thin. So there's a good correlation between the OCTA and the nerve fiber layer thickness map on OCT. And this is another example where it's compared with the visual field. So if you can see, there's very subtle change in the the right inferior quadrant of this frame on the OCTA as compared to the remaining, and the corresponding area in the upper hemifield is showing some the scotoma in the pattern deviation plot in the visual field. So there is this. So you can see even for an early disease, the OCTA seems to be picking up those signals, or the loss of blood flow related signal in the OCTA. So can it help early diagnosis of glaucoma? So the whole image vessel density and in the peripheral area, and the nerve fiber thickness, in the healthy and glaucoma suspect, they almost give you a similar result. So that means they are comparable. And also OCTA measured peripapillary density and peripapillary retinal nerve fiber layer on OCT is comparable in distinguishing mild glaucoma from the control eyes. So there is kind of an evidence in the literature that even in early glaucoma, the OCTA and the OCT as well the visual fields, they correspond. So that means even in early glaucoma, there is a potential for the OCTA to pick up glaucomatous change, vascular defect, which could be because of glaucoma. So OCTA measurement detected glaucomatous changes in macular density area without any evidence of these. Now this is important because we do the the GC the macular area OCT, and if you do the macular area OCTA, it was seen that maybe OCTA could help us diagnose these conditions a little early. So there's a good discriminatory ability of the peripapillary area, and can it detect progression? So again, these are two images which are taken of the same patient, same eye at different intervals, and as you can see on the retinal thickness map, there is some decline over a period of 11 months, and similar decline is also detected in the OCTA as well. So there's again an indication basically which suggests that it's not moving. Can you move a few slides further? Yeah. So that suggests that OCTA can also be used for progression. So there is a structural and functional correlation in OCT, OCTA, and the visual fields as well. Another advantage of OCTA is that in advanced glaucoma, OCT reaches a floor effect very fast, and after that you can't, in advanced glaucoma, you can't, OCT relativity or the use of the OCT becomes a little less, whereas OCTA, the flooring effect comes much later. So even in advanced disease, when OCT is not used, OCTA could still be used for measuring progression. So to summarize, OCT is a non-invasive tool to study retinal vasculature and has several advantages, and it correlates well with the other modalities of glaucoma diagnosis, and it has a potential to pick up glaucoma as well as glaucoma progression early. And is it also seen that areas where there is a OCTA changes are there, and even if the visual field and OCT is normal, those people tend to develop visual field changes later on. So maybe there is some value in prediction in the future course as well. Thank you so much, and thank you once again, AIOC and Dr.
Thank you, sir. Do we have a quick question for Professor Panda before we move on? Right. So I think Dr. Sunita is caught up in another session. So we'll just do a follow-up of the case scenarios showing fallacies, and we'll take Dr. Sunita's talk in the next 15 minutes or so. She said she'll come. Right. Right. So while the slides are, here we are. So I thought it's nice once we have a background to just go over real life. Why is it moving on its own? अपने आप क्यों चल रहा है slide? अभी तीसरा पे पहुंच गया without me doing anything. All right. Okay. So ये अभी, are you sure? ये अपने आप हिल रहा है, माउस मेरे हाथ यहाँ है. All right, sorry. So I thought we'd look at some OCT fundamentals. So I don't think we require any AI or any machine to tell us that the right eye up there has glaucoma. There's an inferior nerve thinning. There is RNFL loss, if you can see that. And there's obviously a notch. And obviously the visual field shows superior visual field defects, which are along with that. And of course the OCT shows up the red at the bottom corresponding to this little notch here. So I don't think we require any machine or any gadgetry to tell us this. But like Dr. Faisal said, the GCC is completely normal. Now, is it normal or is it green? You can see that there is a bit of red over here. So the thinning has just started. And the fundamental to understand that is that you first have a ganglion cell loss here. Then you have an RNFL defect because by the retrograde transport which is lost at the lamina cribrosa, the retinal nerve fiber layer gets thin, and that is what we see really as an RNFL defect on the OCT. So in the real world, the first thing when we don't do an OCT It's a limited use when you have peripapillary atrophy. If you have an atrophy like this, the retina is just not segmented enough within the 3.4 millimeter circle, because it's not segmenting retina because there's no retina there. So in discs like this, there's no point in even thinking of doing structural imaging on the OCT. If we need to do a structural imaging, then what is going to help us is the HRT, because the HRT gives a circle around the optic disc, and it's going to look at the neuroretinal rim. It has nothing to do with the retinal nerve fiber layer, and that is why if you need to do structural imaging in eyes like this, if at all, then you need to go for the HRT. So that's one fundamental. The second time never to do an OCT is in very advanced glaucomas, which is what they come to us, unfortunately, with blinding glaucomas like this. This is what a 10-2 field is like. And when you have fields which are splitting fixation like this, OCT would give very little information because of the floor effect. No PLIs have a thickness of about 40 to 45 microns because of the glial cells there, because of the structure, even if there's no function. So the OCT is not going to be going to image anything less than that, and which is what lands up in a floor. So this is all blue. It's not going to get any worse. It's not going to get any better. So we don't need to do the OCT to follow them up. Functionally, it's important, and what we need to do now is probably move on to a macular threshold, because then we'll be able to see each of these numbers and actually objectively see if the sensitivity of the retina is going down compared to the OCT. So these would be two situations clinically where I would not order an OCT. Even for follow-up, this question was asked. This is an example of that. If you see this, this is showing up as progression. This is possible progression. This is likely progression, similar to what we are used to on a visual field GPA. And yet, if you just go back to your optom and say, listen, this signal strength is 4 for some reason. Can you please focus it better? When the signal strength goes back to 6, this so-called likely progression also disappears. So the scan quality is so important. A little bit of inattentiveness, a little bit of dryness in the cornea can show you an OCT, which progressive glaucoma, which is not true. So we need to be careful about these things. It's not the color. So this is a patient of early primary open angle glaucoma. Again, we don't need a machine. We can see the RNFL defect there. We can see the visual field nasal step coming up, that little bit, very early glaucoma, but good to pick up, because these are the glaucomas which have to be treated in time, and they're going to live normally for the rest of their lives. If you see the GCA, it's white. If you see the OCT, there are whites and there are some greens. Now, does that mean that this patient is normal with a visual field defect? I don't think so. What is happening is this RNFL, for some reason, this patient has a thicker RNFL than normal. The normative database, there are areas which are more than a normative database as well, it's in white. So it's a thick RNFL, and the early loss here is simply not coming in the 95% of thickness which is required, but it is thin for this particular person. So having green, having red and yellow does not preclude glaucoma. So green is not normal. If that's one message that we could go through with this IC, you can have manifest glaucoma and your wonderful OCT might still show up green, but it's not showing up normal. So that's one. Second thing, structure and function on OCT if it's not correlated. Now, this is a lovely structure function analysis which is possible if you have the Cirrus and if you have the Zeiss visual field machine together, or the Humphreys together. So what they do is they reverse the visual field defects to come on the OCT. Now, if this is not commensurate, you have this large nasal step, but this is all green. So here, again, it's not correlated, and we need to go back and see what the problem is if it's not correlated. So that's a red herring, that visual field defects in both eyes don't seem to be matching a structure, which could also mean that the visual field defects is in the learning curve of the patient, because there is nothing structurally seen in both optic nerves. Now, this again, right eye has glaucoma. There's no doubt about that. And even the left has glaucoma here. An early glaucoma and a central visual field defect, most likely normal tension glaucoma. But look at the OCT again. The left is green. Now, does that mean that this visual field defect and this RNFL defect are not significant? It doesn't. We know clinically, of course, it is significant. But if they're going to walk around with this, one would think that this is normal. And yet, if we go on to the ganglion cell analysis, it's amazing that both of them probably have potentially blinding glaucoma, both eyes. And yet this OCT comes up as green. Now what's happening here? What's happening here is, what has been seen is, there is a topographic arrangement which tells you what the OCTs would come up with. What that means is, if you have an RNFL which is nearer, a defect which is nearer the papillomacular bundle, then it will show up on the GCA. If you have an RNFL defect which is nearer the poles, it will show up in the retinal nerve fiber layer, simply because it's bypassing the ganglion cell in that case. But if it's in the papillomacular bundle, then it's not coming in this normative database, which is why the retinal nerve fiber layer analysis is not picking up a defect which is closer to the papillomacular bundle. But these defects are dangerous, because these defects are going to split your fixation and the ones that are going to cause blindness. So don't let go of an RNFL which shows up as green, because they could be blinding glaucomas, which is why we do a GCA in every single case now. It's coming up. Now we started doing 10-2 fields for early glaucomas as well, simply because the resolution of 2 degrees picks up central defects better than would be picked up by the 6-degree resolution of a 24-2. So this is an obvious glaucoma again, isn't it? 57 years, 6'6", 25-36 pressure, small crowded disc, most likely angle closure. There's no doubt that these small discs also, even if it's a 0.6 cup, this is likely to be glaucoma. Of course it is. It has 36 millimeters of mercury pressures. Now, there is an RNFL defect here as well. If you see it really carefully, look at this RNFL. It is completely white, and here you can hardly see it. So I don't think clinically we should have a problem. And you have superior defects in the visual field in the superior area as well. And then again, look at your OCT. Again and again, a green OCT would pop up at you for something which is so obviously glaucomatous. Again, because it's a small crowded disc, because all the retinal nerve fiber layers are stuck into that small optic disc curve. And because of that, since they're all crowded together, if you actually see 172 microns in the right eye and just 92 microns in the left eye. So close to 80 microns loss in one eye, and still not picked up, because it doesn't fall in the 95% of thickness values. It falls amongst the 5%. So it's still green, but it's not normal. Now here's another one. Who would say this is not glaucoma? There's a cup, there is a disc hemorrhage, there is an RNFL defect, there is a visual field defect. So again and again and again the OCT is coming up as green. Now what is happening here? This is something very interesting, that if you have an active disc hemorrhage, and something which we've noticed, the OCT has a little bump here. Possibly because it's extravasation of fluid locally in this area, and the OCT is a machine which just picks up thickness. So if the peripapillary RNFL is a little thick because of exudation, because of hemorrhage, despite all these signs of glaucoma, the OCT still tells you that it's green, but it doesn't tell you that it's normal. Now, this 64-year-old has loss of vision, pressures of 12, and has a relative afferent pupillary defect. I wouldn't be too conscious of glaucoma in a patient like this. And if I see the discs like this, even though they would all be referred to the glaucoma clinic, probably the PG would say, how is this glaucoma silly? This is so pale. The neuroretinal rim is pale and there's not too much of cupping. So pallor more than cupping should be neurological. And it's probably old AION. But the OCT shows up marked thinning. Of course, it will show up marked thinning. Whether it's because of AION, whether it's because of glaucoma, the fact is that the retinal nerve fiber layer is not normal, it's thin, and that's what will be picked up. The point is, red is not glaucoma. Any thinning, PRP scars with a lot of RNFL thinning, ganglion cell loss, RNFL thinning will be red, but it's not necessarily glaucoma. So you can have red without being glaucoma. So I'm very scared of small discs. Small discs might be obvious glaucomas and the OCT would be green. Small discs could be at risk, they could be AION and the OCT could be red, but it's not glaucoma. So it's very, very important when you see small crowded discs to spend an extra minute and say, are we missing something? Now, sometimes it's red. So this patient was very interesting and it's a very learning thing for us. So one eye, she'd lost trauma and told that the left eye has glaucoma and she was going around. And why do you have glaucoma? Because there is red on the OCT. So you can see this red. So because there's this on the OCT and there's this on the OCT, and therefore you better be careful because you've lost one eye and this eye might have glaucoma. And when we looked very, very hard, if you can understand and see this, it's red, but it's also black. And as Gaurav said, if it's black, it means that it's not being imaged. And if it's not being imaged, then there's something in front. There's something else that's going on. And, sorry, this hasn't worked. There was a little gola here. This is actually the PVD, the Weiss's ring of a PVD. And we've now started noticing that when you have PVDs, these are what the OCTs come up with. And actually on the color graph, it's black. If it's black, it's front of the retina, and that Weiss's ring is the thing which causes, because the RNFL is not imaged there. So completely normal eye can also have a little bit of red, and they can go around being labeled glaucoma, though they don't have it. Again, early glaucomas, right? So there's no doubt about this RNFL defect. There's no doubt about the early nasal step, and yet it doesn't show up on the OCT. Now, why doesn't this show up on the OCT? This doesn't seem to be very crowded. There doesn't seem to be anything else going on. Now, what happens is, look at the left eye. Now, the white areas again denote thick RNFL de novo for this patient. Inherently thick, but the thinning falls in the normative database. And if you blow this up, you'll actually say the thinning is beyond the usual RNFL which is being imaged. So this machine has just not been able to pick up an RNFL defect which is there. And there's something else that we've also noticed, that the clock hours on OCT are very arbitrary, right? So RNFL defect may actually bisect a clock hour. Half the defect has gone into one clock and half the defect has gone into the other. But the clock hour per se, on the average, turns out to be normal. So when you have things which are bisecting, that is also interesting. I'll just take 30 seconds. Can you move this? Right. So the approach to any patient depends on what it is. And what it is will be evident more often than anything by sound clinical judgment. And OCT does give a structural assessment in terms of thickness, but a qualitative fundus exam will give you many, many clues. And I acknowledge all the residents and senior residents who helped me put these patients together and give me all sorts of information when I need it. Thank you. Thanks a lot. And I think Dr. Sunita is here. Can we take a quick question before she comes on? Sunita, you're last, but we have just about time. Any quick questions, then we'll close after Dr. Sunita's talk. Yeah. Yes, I suppose. I think I was just trying to make the point that green doesn't mean normal. So usually it's the RNFL printout which is going around. Most people would not do a GCA or a GCC for routine glaucomas. So the idea was just giving, but yes, I suppose the GCC might have given us more clues if we had done that. Correct. Point taken. Yeah, so Dr. Sunita, she's at the Shroff Charity Eye Center. I think Dr. Sunita ka presentation tayar? Ready? Yeah. So I invite her to give her talk on glaucomatous versus non-glaucomatous optic neuropathy. Can the OCT give us some clues? Sunita, please.
Thank you, Sushmita, for having me in this IC. So can OCT distinguish between glaucomatous and non-glaucomatous optic disease? So the differentiation can be difficult, especially in clinical practice, and optic nerve pallor is often used in discerning glaucomatous versus non-glaucomatous optic neuropathy. However, the identification of pallor is often variable and dependent upon the clinical experience. So the pattern of RNFL loss, macular GCC, and ONH topography findings on OCT scans may provide clues on DD of these optic neuropathies. So these are the common neuropathies which can mimic glaucoma on OCT: ischemic optic neuropathy, optic neuritis, compressive optic neuropathies, etc. So coming to AION, which is the most common optic neuropathy and the second most common cause of permanent optic nerve head visual loss in adult glaucoma. As we know, in acute stages, there can be optic disc edema and optic disc pallor in the later stages. And most often it is associated with small optic nerve head and no cupping and the altitudinal type of visual field defects. So these findings can also be seen on OCT if you carefully look at the OCT picture. As you can see here, in this particular eye, there is in the left eye, there is no cup at all. And in the right eye also the cup is very small. And there is a diffuse RNFL loss which doesn't correlate with the optic disc cupping. So as we know, AION is more common in crowded discs. So this finding correlates well with the disc findings. And similarly, it affects macula more, so that you will get asymmetric loss in two eyes, especially if the disease is there in one eye. So the OCT can definitely give some clues. In AION also, there are small discs and the pallor is there in the superior half of the disc, which correlates with the inferior changes in the visual fields. And you can see the macular changes in the inferior quadrant as well. So the differentiating points on OCT are that the RNFL thickness map shows diffuse RNFL loss, which is not same as glaucoma. In glaucoma, we'll get superior and inferior quadrant losses, and CTR is not consistent with the amount of RNFL loss. And in glaucoma, often the CTR is consistent with the amount of RNFL loss. So the lack of concordance between the degree of cupping and RNFL loss and visual field defect should be helpful in differentiating these two disorders. Again, in optic neuritis, there is acute optic neuritis, there is severe disc edema. That time it may not be possible to take the OCT picture, but sometimes if the visual acuity is good enough, then you see this very thick RNFL because of the edema of the optic nerve. So you will see exceptionally high values in the RNFL, as you can see here in the left eye, which is beyond the normal limits. And you can see the CD ratio. Again, the cup is very, very small or absent. There's no cup here. And the RNFL thickness is very high. So after a few years, after the attack resolves, you will see the damage in the temporal, especially in the temporal quadrant, as you can see here. So in glaucoma, the damage is in the superior and inferior quadrants, whereas in these disorders, the damage is in the temporal quadrant. And the damage can be more diffuse as well. So this is another patient, as you can see, 3 years after the attack of optic neuritis, the left eye shows significant damage in the temporal quadrant. Again, and cupping is not consistent with the damage here. And this is the first clue for the non-glaucomatous optic RNFL loss. And the second clue is, of course, that there is a temporal quadrant loss rather than superior and inferior. And if you look at the RNFL thickness map of the right eye, you can see this wedge-shaped defect here, again, which is suggestive of past attack of optic neuritis. Although there is no damage as such, there is just a temporal wedge defect. So again, any defect which is on the temporal side is suggestive of non-glaucomatous optic nerve damage. And you can do guided progression analysis also, and you can see there is a sudden loss in the RNFL thickness over a period of time. In a period of just 8 months, there is remarkable loss of RNFL here from 105 to 59. So very fast RNFL damage as the nerve atrophies over a period of time. So again, RNFL loss in the temporal quadrant, CDR not consistent. So these are the major points that CDR is not consistent with the amount of RNFL loss, and highest loss in the temporal quadrant. And the temporal parallel, of course, the clinical evaluation is necessary. Now this, the patient with hereditary optic atrophy. So basically here it is a bilateral condition, and you will get centrocecal scotoma in the visual field and the temporal pallor with temporal RNFL defects, as you can see here in the optic nerve head pictures, and also in the OCT there's temporal damage here and thinning of macular ganglion cell complex. This is nutritional optic neuropathy. Again, the patient who came to us as this suspect with slight temporal pallor, and there's no history of trauma, no positive family history of glaucoma. The IOPs were normal, and there were these definite RNFL defects here on the temporal side. And there were low serum B12 levels suggestive of nutritional optic neuropathy. Now coming to very important compressive optic neuropathy, which is an important cause of monocular visual loss. And the intraorbital and intracanalicular compressive lesions, they cause monocular visual loss. There can be presence of afferent pupillary defect, and there will be central or diffuse visual field defect depending upon the location of compression. So the RNFL, of course, is thinned out. And the clinical history and radiological investigations are very, very important. Here you can see this lesion which is extending into the optic canal, causing compression of the optic nerve and optic atrophy. Again, the cuff will be very shallow with the temporal pallor. So, extent of RNFL loss and thinning depends on the anatomy of the lesion, and absence of RNFL loss in the fellow eye is very, very specific for this. So high asymmetry between RNFL measurements of the two eyes, because these compressive lesions are mostly monocular. So the cause of monocular visual loss or RNFL loss, and especially in patients who are diagnosed as normal tension glaucoma. And if the glaucoma is progressing in one eye with normal pressure, it's very important to check for any compressive lesions. So in this particular patient, he was diagnosed as a normal tension glaucoma. The CD ratio was also high in this particular patient, but as you notice, there's no inferior RNFL damage here, which should be there in case of glaucoma. And there is absence of RNFL loss in the other eye. And so there is a high asymmetry between the RNFL measurements of both the eyes, which is an alarming sign for non-glaucomatous optic neuropathy, especially in patients with normal tension glaucoma. Again, in macular GCC, only one eye is involved, the other eye is absolutely normal. So again, this is alarming, and a patient with normal tension glaucoma with normal pressures and unilateral, especially unilateral glaucoma, should be investigated for any compressive lesions. So apart from OCT, there are other differentiating features between glaucomatous and non-glaucomatous optic neuropathy. Non-glaucomatous optic neuropathy is more common in young age, pallor is more common, then they mostly involve papillomacular bundle, and therefore temporal loss is more common as opposed to superior and inferior loss in case of glaucomatous. And they respect most of these conditions, especially the compressive lesion, they respect vertical meridian, whereas NION and they cause altitudinal defects. They are usually unilateral, especially in exceptionally in hereditary optic neuropathy and few congenital disc anomaly. And you require to do other investigations, and they may be associated with other factors like vasculopathy, nutritional and systemic diseases. So to summarize, as we know, glaucoma in patients, they follow the fields, and OCT, they follow this horizontal meridian. So this is the horizontal raphe, which is seen in glaucoma patients. The neurological disorders respects vertical meridian, and the AION and other lesions, the ischemic disorders can cause a diffuse loss of RNFL. So the degree of ONH cupping is generally disproportionate to the extent of RNFL damage. Significant pallor is there in non-glaucomatous, and pattern of RNFL loss can be different in non-glaucomatous optic neuropathies compared to glaucoma. Macular OCT shows vertically oriented thinning. However, in presence of typical RNFL loss and glaucomatous cupping, non-glaucomatous neuropathies must be ruled out, especially in cases, as I said, with a diagnosis of NTG and a comprehensive evaluation including visual field, visual acuity, color vision, and pupillary light reflex are very, very helpful in differential diagnosis, and of course, radiological imaging if you're suspecting a compressive lesion. Thank you very much.
Thank you, Dr. Sunita. So I think Dr. Rajul has been held up and he couldn't come. So before we conclude, we could have a couple of questions or a discussion. Dr. Pandav, if I could start off the kickstart. Can we have a mic, please? Yeah? Excuse me? Can we have a... Okay. So if we can kickstart it, sir, before the OCT angiography, since it's on blood vessels, do we need to take care of vascular problems in the patient, hypertensives, diabetics? Could that erroneously affect the interpretation of an angiography?
I think the idea is that the circulation plays an important role in genesis of glaucoma. So I think if you look at the classical hypothesis, the theories, I think the mechanical and vascular theory, they're still kind of the predominant ones. There are other ways of developing glaucoma, but I think these still say theirs. The problem has been we can't really study the vasculature, the blood flow of retina in a very objective, convincing manner. Like we have been doing Doppler, we have been studying the carotids, but they are very gross, and also the orbital, using ultrasound. But I think there's a problems with the methodology, the reproducibility, and there's always a bit of a question mark. So OCT gives you a little better, kind of a more objective way in looking at the retinal vasculature. So I think we are getting a little more newer information now that how this can be. However, having said that, the OCTA also doesn't give you the actual flow; it's only deducted flow. So, but still, it is useful, some tool there. And regarding the question that whether looking after the hypertension and other things, definitely, because we are not kind of treating patients in isolation. The patient is a patient. He would have diabetes. Some of them would have diabetes. Some of them would have, hypertension, low, high blood pressures, sleep apnea, and many other autonomic dysregulation. So they're all there as a package in a patient. So which one is actually, causing damage, we don't know. So we have to look at in a holistic manner. And I think if OCT is showing some change, then we take it as a change which could contribute towards glaucoma. So that could be one factor which can be addressed. So if you get that picture, then you can dig a little deeper into it. Okay, does he have sleep apnea or something else to account for that? And if it's there, so we address that. So it doesn't matter whether this is a purely vascular or other thing, but important thing is that we can offer something to the patient which can help him.
Yeah. Thank you. And Dr. Sunita, the question always is asked is which normal tension glaucomas should we image? Should we image all? Can OCT give us insights as to which normal tension glaucoma should be sent for imaging, or doesn't matter? Yeah, okay.
So OCT, I think, is helpful in normal tension glaucomas and in deciding which patients should undergo imaging. So as I said in one of the examples also, that if one eye is progressing very fast, so it is unilateral, or if it is highly asymmetrical between the two eyes, then one should, and especially in young patients. So because compressive lesions may be more common in young patients if it is highly asymmetrical, and if it is not following the typical typical glaucomatous pattern of loss, like superior and inferior, if it is more on the temporal side involving papillomacular bundle. So I think these are the candidates, and if they have some other symptoms also, so the entire like pupillary light reflex and the afferent pupillary defect, So I think all these are the
So
indications.
maybe
of,
also the topography of the defects. If it's
topography.
superior and
If it is
inferior,
superior,
then it's
inferior,
more
or-
likely glaucoma.
glaucoma.
But if it's towards the papillomacular, it's
Bundle,
possibly it's
so
more.
it is.
That
So
could
OCT
be
is
one
helpful
in that sense.
but
yeah.
all the patients do not require imaging,
Yeah.
especially the young patients with highly asymmetrical glaucomas, because there are so many other causes of normal tension glaucoma.
Yeah,
Compressive lesions are just one of them.
And Dr. Faisal, regarding the use of the OCT versus vis-a-vis visual field, I suppose the stage of glaucoma would matter, isn't it? That if we had early, we would concentrate on one, and if we had, even, or do you need both in all? What would be your current practice of using OCT?
For early glaucoma, the structural changes, especially in the pre-perimetric stage, and the visual field may not be picked the decision. So in the early, it's good for OCT is good for the early glaucoma, but we already discussed in the at advanced stage there is a floor effect, so the OCT won't be showing much changes because of we have lost all the ganglions, and still there is a remaining structure of supporting structures. So that scenario, the visual field is a good. So if you have luxury of both, you can do as a structural functional correlation if you have the both visual field and the OCT imaging, if you have both.
So there's one question I'm going to ask across the panelists and maybe take a head count on that. Would you treat somebody with normal visual fields and an OCT thinning? So I'll start with Sunita. What would be your take? That's one question which I've been asked so many times, so I love taking different. What would you do? You have a patient who has, say, ocular hypertension with an OCT thinning, but visual fields normal.
Earlier, I think now my opinion has changed,
Okay.
because earlier I used to feel that visual field is a gold standard.
Okay.
But it is gold standard for perimetric glaucoma. There's certain, entity now which is very well known, pre-perimetric glaucoma. And if there are risk factors, I think risk factors are very, very important.
Yeah. Okay.
And we do have patients who have advanced damage in one eye and the other eye is absolutely normal, which if we don't treat, it will definitely progress very fast. And I have quite a few patients who progress very fast if one eye has damage.
Okay.
Even if none of the eye has damage, there's a very strong family history of glaucoma.
So
The
one
IOP is
indication
high.
would be fellow eye of a glaucoma.
Yeah.
If they have an OCT change and even if the fields are normal, we would
Yes,
so
yes.
that's one message.
That's one.
Okay.
The other is strong family history.
Okay. Strong
Where the
family
parents
history.
or other
But how do
siblings-
we know that thinning is not de novo to that patient? How do we know that you're subjecting that patient to, suppose that fellow says, okay, I'll come back every year and do my OCT. I mean, would that be
See,
a
I have seen
consideration?
progression in 3 to 4 months also,
All right.
with the development of disc hemorrhage, and then
Okay.
although that progression may not be that fast, it will take years, but then we should warn the patient that he can progress or she can progress, and then I think it is better to start treatment in patients who are at a high risk. I think the high risk is family history or other things, the hypertension.
So OCT, you're saying, would be an additional tool to decide management whether or not.
And
so there would be
if it is reproducible, maybe if you just repeat the OCT
Yeah.
after 3 to 4 months and the changes are reproducible and they are correlating well with the optic disc changes. And sometimes there are patients who have disc hemorrhages, RNFL, loss with OCT clinically on the disc photograph or clinically, and then the OCT changes also. So I think we should discuss the pros and cons of treatment with the
both, yeah.
patient, and there is no harm. There's no hard and fast rule that every patient has to be started, but I think that is in my opinion, I think that is important. If the patient is showing damage on OCT, then that's an important consideration for starting treatment.
I think for us across, this is again looking at the Mount Everest from other phases, change is important.
Yes, changes him. That is
So
what I'm
if the
saying.
fields are normal
Yeah.
and I detect one, I would still probably tell him, look, I'm not sure, this
Yeah.
is there. But if I detect change in anything, if a visual field, because even if there's one visual field defect or
Yeah.
one nasal thing which does happen, it's okay. But for me, a structural change would warrant treatment prior to that, because treatment is such a thing, and a labeling. But that's what.
But
Faisal,
only-
what would be?
only
Gaurav, what
thing
would be
is-
yours now that you're. So let's take the perspective of So Sunita is in a semi-private, semi-institutional, large institutional practice. We are completely sarkari, right? And Gaurav is completely corporate. So let's hear his take on
So,
if you have a change.
Ma'am,
And
from,
what do you do? Tell to the patient. Okay, in the corporate, do you do OCT and fields for every
yes, ma'am.
patient?
For every
Patient that-
patient we do,
you do both.
because not only for the diagnostic purpose but for
Okay.
medical legal purpose also, because patient wants a documentation.
Mm-hmm.
Like we were discussing, in cases of advanced glaucomas, OCT is not that helpful, but we need to do it for documentation purpose, because it is easier to tell patient and show that there is a thinning and the amount of damage is too high that they need regular treatment and follow up. In terms of pre-perimetric glaucoma, I routinely see a lot of pre-perimetric cases which we don't know if they will progress or not. So in my personal opinion on
So pre-perimetric, you mean 24-2 fields are normal, but they have a change on OCT, or the disc is suspicious and the OCT is
they
fine?
have a suspicious disc
Okay.
with red on
Somewhere,
OCT,
okay,
with
all right.
somewhere red on OCT.
Okay.
So I will agree with ma'am that if the patient is high risk and that there is a family history, because there are two kinds of patient in glaucomas. Some people are not bothered, they are, and some people are very over bothered. We rarely see patients who are in between. So if they are very over bothered and there is a family history, so we need to treat them, and we should treat them, and we can keep them on regular follow-up.
Okay, so hypothetical situation,
Yeah.
you've treated somebody with one change in OCT, and maybe of course, if it's high pressure, there's no problem.
Yeah.
The problem is if the pressures are less than 21, should
Yeah.
you treat, or maybe 22 or something? And then you treat them, and then they never develop it. And 2 years later, he comes and says, you wanted to make money out of the pharma company. I didn't have glaucoma. You've treated me unnecessarily. Now I've landed up with a preservative allergy or something. Then what do you do? I mean,
ma'am,
that's possible.
it is very
isn't it?
difficult to prove or say
Yeah.
that in 2 years the glaucoma
No,
has
no.
not
My
progressed.
take, why I'm asking this, not
No,
to
no,
rag
because-
you. I'm just asking this, that suppose you had waited,
Yeah.
and tell him, look, you were 120 microns, now you're 90.
Yeah.
If we don't treat, you'll get a field defect, and
Yes.
let us start treatment.
Second point
Could we do that?
that comes is the patient can come. Patient understand that he can come for a regular
Yeah.
follow-up. If he can come every 3 to 6 months and get a routine IOP and 6 monthly OCT.
Yeah, just an
follow-up,
OCT and nothing else, and
Then
then-
definitely, like I have with the patient with IOP of 22, normal field, no family history, nothing, and with borderline higher CCT, but one area was red in one clocker. And he agreed that he will come every 3 to 6 months. And he since followed up like 1.5 years, and he has not progressed.
Yeah.
So I have kept in yeah.
Oh, that normalcy is also a little subjective. Yeah, ma'am was
Because-
saying something.
Yeah.
Yeah. No, I think for most of us, swap is out. Swap is difficult to do. It takes a long time, and it hasn't given us any additional information vis-a-vis the white on white. But what we have gone on to for pre-perimetric is 10-2. So the concept of doing a 10-2 for only advanced cases is sort of going a little on its head, because we've now understood that 6-degree resolution might miss central defects. So we do a 10-2. So now, yes, we ordered 10-2 initially and a 24-2, but now you have 22-4-2C, where they have 10 additional points, which are with a 2-degree resolution. But that's not nice for a perimetrically naive patient, because it's CETA faster and it's a threshold test. So there's no thresholding, it's supra-threshold, it's yes and no. Somebody who has never done perimetry in his life would be a little hesitant in, pressing. So our standard is always do CETA standard as first, and once they learn the perimetry, we go on to the 24-2C. Right. So I think I invite Professor Pandab for the next. We carry on. PGI carries on with glaucoma next session as well.